Our next speaker is Dr. SUPRIYA Singh from Kolkata, and an extremely prolific, capable surgeon and senior consultant at the Eye Care Center in the city center. And she was going to tell us something more challenging, like it's a small pupil situation now and how she would proceed. On to you, Dr. SUPRIYA.
Thank you so much, ma'am, and good evening, everyone. I'll be discussing about the management of small pupil in SICS. There is no set numerical definition of small pupil, and it is completely subjective. The size of the pupil for performing a comfortable cataract surgery depends upon the grade of the cataract, skill of the surgeon, and other associated comorbidities like pseudoexfoliation, eye frills, corneal scar, posterior synecdoche, etc. So, for me, the definition of small pupil is any pupil size or cataract surgery.
Can everybody mute themselves? No.
In this patient, although the pupil size is just 5 millimeters, but since the cataract is soft, so it can be easily managed without any additional maneuver, and this does not count as a small pupil for me. Whereas this patient of corneal opacity and adherent glaucoma, because of the corneal opacity, the view in this patient is limited, and so even a 7 millimeter size pupil will also count as a small pupil. Now, the three most important factors which I consider while operating in cases of small pupil are appropriate capsular staining, adequate capsulorhexis, and sufficient hydrodissection. For capsular staining, I employ the technique of capsular painting as described by Dr. Kokar. In this, the anterior chamber is filled with either HPMC or 1.4% Helon GV. The tip of the cannula is placed just below the pupillary margin, and dye is released while making a sideways sweeping movement. This way, dye is released onto the anterior capsule, and it ensures uniform staining of the anterior capsule, including the portions peripheral to the pupillary margin, as can be seen here. I usually aim for a slightly larger axis, approximately 6.5 to 7 millimeters, depending upon the grade of the cataract. And I spend few extra seconds to make sure there is good hydrodissection, as if we do these two steps properly, it saves many complications like PCR, zonular dialysis, and vitreous loss. But doing a good rhexis and hydro might be difficult sometimes in small people, so various techniques are employed for pupillary dilatation. The first among such is use of adrenaline. I prefer to use intracameral adrenaline. Some surgeons use high molecular weight viscoelastics like Helon 5, but I prefer to use the usual HPMC, and most of the cases dilate with simple adrenaline and viscoelastic. In cases of posterior synecdoche, a synecholysis is done, and if there is a membrane, then even using manual methods, membranectomy is done. And once again, in most of the cases with synecholysis and with the use of the adrenaline, pupils dilate. For obstinate pupils, more aggressive measures are employed, such as stretch pupilloplasty. In this, two instruments are placed to stretch the pupil at diametrically opposite points. Usually, Kugelin hooks are used, but one can also use dialers or sometimes chopper if Kugelin hooks are not available. Another technique is the use of syncrotomy, in which multiple tiny cuts are made in the iris. Care must be taken not to cross the collarate while cutting the iris. The subincisional pupil can be easily approached through the side port. Now, both sphincterotomy and stretch pupilloplasty are quite inexpensive and easy procedures, quick procedures, and therefore they are more frequently used in SICS, especially in camp surgery. But there are some specific scenarios where hooks and rings are more useful. Like in this patient, had spheroidal degeneration of cornea and pseudoexfoliation, so I decided to use hooks for better visibility. Now, while using the hooks, care must be taken not to overstretch the pupil, as it may damage the sphincter permanently. This is another one-eyed patient who had complicated cataract secondary to uveitis, and I decided to use rings, as rings are less traumatic. Most of the times, as soon as hydro is done, I remove the pupil expanding devices, but there are some expansions like if pupil is extremely small, and in cases of zonular dialysis, I prefer to keep it until the end of the surgery. Now, this is one particular case where the rhexis was done, and after completing the rhexis, I realized that it was very small. Since I have done a sphincterotomy, it was difficult to put rings or hooks. So therefore, I made some small nicks in the anterior capsule for safe delivery of the nucleus. To conclude, do not compromise on the size of the rhexis and good hydrodissection. Do not hesitate to use different techniques of pupillary dilatation. Thank you so much.
That was a wonderful presentation, Dr. Supriya, and I really introduce you. You are from one of the most major assets for Dr. Debashish Bhattacharya from Disha Eye Hospital. So I'm sorry for not having introduced you adequately, and that were amazing set of surgeries which you showed. So let's go on to the discussion. Like many of the cases which she had shown, I'm generally referring to all the expert panel. If it is a phaco surgery, I would have thought of using an iris loop primarily. But those challenges are less in a SICS. So would you, if you are asked to choose between one of them, would you do a stretch pupilloplasty? Would you do a sclerotomy? Or would many of you use iris hooks in most cases?
A pupil expander, Chitra, it's a question.
Yeah.
Because here, you need to take it out. So
Yeah.
iris hooks for the beginners are is the thing that has to be used. Now, Dr. MS, I've seen him, and even I also do at times. Yeah, we can do a big rhexis under the pupil, but that is all imaginary.
Yes.
What Supriya stressed, and that is very important, that the incision on the lens, that is the capsular rhexis, has to be adequate for the nuclear size.
Yeah.
Any disproportion, and we try to bring the nucleus out, I mean, there will be zonular dehiscence. So this thing has to be kept in mind. This is the most important thing that has to be kept in mind. So like if we are seeing, and one thing like the experienced surgeons do is to drag the nucleus so that the equator is visible in the pupillary or near the pupillary area, and then give a little pressure so that the equator of the lens nucleus is out of in the pupillary plane. Once you get that situation, you can walk on the equator of the lens with two coplens, and then it actually usually just rolls out of into the anterior chamber. But the multiple release of the the rhexis, if we should not be using unnecessary forces to prolapse the nucleus into the bag, we should assume that the rhexis is inadequate to the size of the nucleus. And obviously, the use of the iris hooks for the less experienced surgeon is a mandatory thing.
Yeah. Anybody has anything else to add?
I think the SICS, the sphincterotomy will be a better option instead of having multiple incision in the cornea. So this will be a better option because ultimately we are going to give good vision. Aesthetics can have a second period.
Okay.
Dr. Chitra, I just wanted to say one thing, that a good examination in a case of complicated cataract because of uveitis is very important. And one must see where the synechia are there, whether there is any fibrous membrane there or not. Many a times, if you simply remove that membrane from the pupillary margin, the pupil will dilate. That many a time we miss because we have not examined the patient under slit lamp. So that is one aspect that one should take care of. The other important thing is, as iris hooks are very, very handy and you can use that. And one should not forget to give oral steroids, because it should be done under cover of steroids if there is uveitis. Many a time these days we are straight away going to the OT and operating them. and steroids are not given, and post-operatively suddenly we get a severe attack of uveitis. So these two things are important. Otherwise, rest of the things have been told by the others.
Yeah. Before we move on, one last challenging moment for small pupil. Supposing you had a PCR in a small pupil and the iris is also mildly traumatized, what would you do? Would you still stick to an iris IOL, or would you look at PC IOL, or would you think of doing a scleral? I just want to understand whether the approaches are going to be different in SICS as against PACO. Am I heard?
No, a lot of disturbance was coming.
Yeah. Did you get my question? If there is a PCR in a small
Yeah, Chitra, we got your question. The
Yeah.
thing is, everything should be visible. Like you see that with a small pupil, you have done something and now there's vitreous in the anterior chamber. I think the first thing we need to do is, as Dr. Sahu said, well, sphincterotomies. Well, I have my reservations for sphincterotomies because you are going to enlarge the pupil. And if it is a relatively young patient, then a bit not a very comfortable post-operative situation. So we have to get in with hooks. Now, once we see, we have to understand where is the PCR and the extent of it. What is the capsular rim which is left? I mean, is it intact or is it compromised in one or two places? Then we can actually place a lens in the sulcus. That is not a big deal. And we can do vitrectomy, clear everything, see that everything is clear, and then put in a intraocular lens. I think PCR management with SICS is much better because we don't have to deal with, even if there is a big nuclear fragment, we need to get bothered, because which in phacoemulsification, it is the time when we convert to SICS. So essentially with the PCR in a compromised situation and compromised eyes like the small pupils, I think we need to see properly and act. So if everything is all right, I mean, why not a lens in the sulcus? We can always give. And for that reason, we have to keep multi-piece lenses in our theater. And we some also give hydrophilic single-piece lenses in the sulcus, which are forgiving, I'm told, but never a hydrophobic lens in the sulcus. Yes.
Okay. Mr. Sunil, there is some noise.
Dr. Chitra, I just wanted to say that in case you have a PCR, you must apply a suture immediately. And if you find that the vitreous has come into the anterior chamber, then one must do a good vitrectomy and then go ahead with this. So applying a suture is very important. Many a times it will go with vitrectomy, and the chances of choroidals are there. So one should apply sutures and do vitrectomy and then should go ahead with the rest of the procedure.
Yes. Any other important point which needs to be covered?
Dr. Chitra, may I add one
Dr.
point?
Kamaljeet, I understand that there's a network issue at your end. I actually switched off my video. Maybe you should not move your phone. No. Yes.
Dr. Chitra, I have one point here. Can I say?
Yes, sir.
Fine. We looked at our endothelial count with adrenaline, and if adrenaline is introduced into the anterior chamber with before injection of the viscoelastic, the endothelial loss will be very high. And so you coat the endothelium with viscoelastic and then only inject adrenaline very close to people. So you have that distance, respectful distance away from this. And the dilution, we worked on different dilutions. The dilution of 1:20 of the adrenaline ampule is the least traumatic to the endothelium. So I would suggest somebody who is using adrenaline should inject it close to people and dilute it 1:20. That also works, and very little quantity of adrenaline is good enough.
Yeah.
The second thing is, ever since we have shifted to topical, whenever there is a mismatch between the rhexis and the size of the nucleus, the only thing patient feels is when you are prolapsing the nucleus from the intracapsular to anterior chamber, if the patient complains of pain, that means you're actually stretching the zonules. That's the only thing which is painful. When you're in the maneuver, the rhexis is small, and when you're given a bulbar, retrobulbar, you will not feel this, but under topical, when the moment pain is there, it means that, especially in a small situation where you're not seeing the capsular bag, if the patient complains of pain, that means there is a mismatch and you'll have to stop, put the lens back, enlarge the rhexis, and then only remove the nucleus.
Yes, two very valid points and really important for us to keep in mind. Should we go on to our next speaker? We did have a lot of extra time because very sadly, Dr. Agni was not there with us. So I could take one more important point to be discussed, if any, before we go on.
Instead
And
of
the role of BHEX in small pupil.
Yes.
No,
Satyajit?
no.
Yeah.
Any pupil
BHEX
supporting device, the device which is taking the support of pupil is a big no in SICS because that hampers the nucleus management. For phaco, it's all right, but for SICS, no, like the pupil expanders which are supported on the pupil, they hamper the nuclear delivery.
Once you have made the rhexis, you could remove it and then the nucleus can be delivered. Will it help in making a good rhexis if you have, because in the last video that we saw, most of the rhexis appeared to be like a blind procedure because the surgeon was experienced. But if we had a pupil expander, we could have at least known that the rhexis has been made properly. And then I agree with you, the expander can be removed and then the nucleus can be delivered.
Yes.
See, Satyajit,
Deepak,
I
any
think
thoughts on that?
I would go with Dr. Boramani, and Irish hooks are the things to go to expand the pupil, because you put a thing again, take it out just for getting a good rhexis. I think that's
know.
not the way of
Waste of time.
it done.
No, I think Satyajit wanted us to think of all probabilities. So what comes across clearly that either you do a sphincterotomy or a stretch pupiloplasty, you can get away with these things in SICS because you are not further challenged by the phaco-dynamics and a floppy iris kind of a situation. And you need to have a larger rhexis, as large as is feasible, as beautifully is told by Dr. Supriya. And of course, going on to the further
At
step.
the end of the day, it's always helpful to have the IUL in the bag. And if you have a proper rhexis, then things are much more.
Can I make a statement here? Can I make a statement here?
Yes,
Please.
yes.
In SICS, nucleus itself acts as a pupil expander when you take it out through the pupil. That also acts as a pupil expander.
Yeah. Yes.
If you can pull the iris that is pupil towards yourself and nudge the nucleus out, it will automatically comes out in a small, but for beginner it is not the right.
Not that.
It's a small pupil, you have to make a big rhexis because you are doing SICS, you have to deliver the nucleus.
Yes.
So at the end of the day, it always becomes a blind procedure when you are doing a rhexis.
Absolutely.
If you want a good rhexis. So
It is, for beginner, the other approach has to be done. They should see and do.
Satyajit, we definitely get the point that you are trying to make, and definitely pupil expander will show me the way how I have done the rhexis and will help me do that. And but I mean, if you compare the price of a pupil expander versus the Madhu Irish hooks, I think the Irish hooks are inexpensive and they work throughout the procedure. So I think I'll always go by the Irish hooks.
we'll move on, man.
Dr. Deepak wants to say something.
Yes, Dr.
Oh, sorry. Deepak wanted.
No, I think the most of the products, most of the things have been covered. My thing was small pupils sometimes are associated with pseudoexfoliation. We have a generalized zonular weakness as well. So many times it's just not about delivering the nucleus out. We may have to see to ensure the CTR is put in, the cortex aspiration has been done properly. for all these situations, you need to see well, and iris-SUPs are still the best bet when doing SICS with pseudoexfoliation in small pupil. So it's not about just dealing with the small pupil. There are coexisting morbidities like weak zonules, and many times the bag comes out when you're trying to do cortex aspiration itself. So we need to be careful until the end of the thing. So iris-SUPs still are the best bet because we can see well, and they help us to introduce the CTR as well. So CTR does have a role to play in many of these cases. So I think that's the way.
Yeah, very,
Thank you.
very relevant, very relevant.